Next we have Dr. Kushal Goud Taduri, and who will be speaking on Phaco endocyclophotocoagulation versus Phaco trabeculectomy in advanced glaucoma.
So, good morning, everyone. My topic is Phaco endocyclophotocoagulation versus Phaco trabeculectomy in advanced glaucomas. Trabeculectomy, as we know, is required in advanced primary open and closed angle glaucomas. And recently, MIGS has gained inroads into the armamentarium of glaucoma surgeries with a greater safety profile than trabeculectomy. Endocytophotocoagulation provides extremely precise laser ablation of the ciliary body in primary and secondary open angle glaucomas, and very favorable outcomes have been reported in closed angle glaucomas also recently in the Indian populations. The aim of our study was to investigate the safety and efficacy of combining ECP with phacoemulsification in visually significant cataract in advanced primary glaucomas, that's both open and closed angles, and to compare it with the current gold standard of phacotrabeculectomy. Ours was a retrospective study, and patients with primary open angle glaucomas who had undergone either ECP or TRAB with mitomycin C with Phaco and a documented post-surgical follow-up for at least 3 months were included. Duration of our study were 24 months, and we included the patients with severe glaucoma based on their HFA criterion of more than 12, and we excluded patients with any previous intraocular surgeries, developmental glaucomas, and secondary glaucomas. Our procedures were performed by a single experienced senior surgeon, and these were our parameters for Phaco ECP and Phaco TRAB. And follow up, we followed them up for BCVA, the number of AGMs, reduction in IOP, and complications. Though they were there could have been some more follow-ups, but we had captured only week 1, 6, 12, 26, and 52 weeks. So we defined our outcome measures as the primary outcome measure. Complete success was defined as an IOP of more than 5 and less than 18 without medication, and the same with medication was defined as qualified success, and failure to meet the above criteria or need for any further glaucoma surgery was termed as failure. Our secondary outcome measures were visual acuity, anti-glaucoma medications, interventions, and complications. So these were our various statistical methods used. And coming up to our results, we included 28 patients with 14 months follow-up in the Phaco ECP group and 24 patients with 12 months follow-up in the Phaco TRAB group. The intraocular pressure, number of anti-glaucoma medications, and the best corrected visual acuity were comparable between the groups, but the mean deviation was slightly more in the Phaco TRAB group. And when comparing the intra-group comparison, that is pre and post procedure in the ECP and Phaco TRAB group, we have seen that there was statistically significant decrease in the intraocular pressure and number of anti-glaucoma medications, and there was an improvement in the visual acuity, but it was statistically significant in the Phaco ECP group, and this was similarly observed when when there was an intergroup comparison also. So coming up to the complications, we had about 10% early complications in the Phaco ECP group and about 25% of early complications in the Phaco TRAB group. And coming up to the late complications, it was about 7% in the Phaco ECP group and 12.5% in the Phaco TRAB group. On comparing the complications, it was found to be just statistically significant between both the groups. Coming up to the interventions, this is where Phaco ECP really scores. We had to intervene only for a single case in the Phaco ECP group, and there was about 79% interventions required in the Phaco TRAB group, mainly being bleb related. And the total success and complete success was comparable between both the groups. So discussions coming up to Phaco ECP and Phaco TRAB, the intraocular pressure reduction and the number of AGMs were similar in both the groups, but ECP scores, because there was a better improvement in visual acuity, the number of complications were less, and the interventions required were very, very minimal. So ECP is the original mix as described by Uram in the early 1990s. It's a diode laser incorporated into an endoscope probe, when we can just insert it with a Phaco wound of less than 2.2 milli. And the IOP reduction in other studies was in the range of 3.9 to 10.9, and the number of AGMs from 0.6 to 1.3. We obtained an IOP reduction of about 10.9, and in both open and closed angles, and the number of AGMs were about 2.7 degrees. The reduction in IOP and AGM is consistent with other studies reported from India. Unlike other ECP studies, we had no serious complications such as choroidal hemorrhage, hypotony, phthisis, or loss of vision. No fibrin was seen. We had only a single case of hyphema. And in our trabeculectomy group, we had a perioperative complication about 41.6%. Advantages of ECP, in contrast to most other mix, it is not at all angle dependent. It is effective and safe. Procedure time is less than half of that of phacotrabeculectomy. Average number of post-op visits are very less. there's absence of a bleb or bleb-related complications, and the limitation of our study was it's a retrospective study, so there could have been a selection bias, sample size, and a short sample size and a relative short follow-up. So combining ECP with Phaco has a potential to be as effective as the current gold standard of trabeculectomy in primary glaucomas, where there is reduction of AGM and intraocular pressure, but the number of interventions required are very, very less. Shorter procedure with no bleb, lesser intraop complications also help ECP in scoring better, and it is safer, repeatable, and always allows for future filtration surgery if so required, if the IOP is not under control. So, thank you.
Why didn't you split the angle closure and open angle separately? Why are you presenting both together?
So
because the mechanism of both treating ECP, angle
Yes, sir.
closure will definitely give you a superior edge.
Yes, sir. Actually, sir, because we have seen, we didn't do that because on comparison, we didn't have so many angle closure patients in our phacotrabeculectomy group. So we took it as primary glaucomas.
And why is your qualified success for both almost equal? I think you have 93, 96 in
Yes.
qualified success.
Yes.
They're on medication, and then again, the phaco traps are again on medication.
Yes, sir.
Why is that? Phaco traps invariably
The glaucomas were, I feel, as you've seen, they were quite more advanced in the phaco trap group also, sir. So I feel that in spite of the trap, they did require some medications.
And what intervention? You had a significant number of interventions after the surgery. No, you had a lot of
Yes, sir.
manipulation.
Bleb
Number of
needling
visits were quite high also.
Quite high in the phaco trap group. Especially it was bleb needling was the most important
How
intervention
many
we required.
percentage of patients have bleb needling?
We had about 60% of bleb needling, sir. Yes.
Oh, thank you.
Yes.